My name is Justin Ringer. I'm I'm representative of a team of individuals from the McGill University Health Centre, which is located in Montreal, Canada. We've been working for the last 3 years to implement a program by IHI called TCAB, which is Transforming Care at the Bedside. It's very similar to the NHS program, the Productive Series. And we've been working at implementing that program, which I'm sure we'll get there. Our primary focus is to teach frontline caregivers how to make process improvements on their own. So teach them the skills and allow them to actually redesign the processes. What we've done is modified, it's not there. Oh, well, interesting. Do you want me to give you it? Do you want me to give you the stick and you can pull it up? I don't want to do that. Okay. So we'll improvise. Glad we're coming prepared. So I was saying, the program that we put in place, TCAB, its focus is primarily to teach frontline caregivers the skills, lean skills, process improvement skills to actually be able to make the improvements themselves. The modification we put on the program is actually involving patients directly in the process. So we teach patients, did you find it? Oh, perfect. Can you just pull it up? Yeah, so just go to that one there, this folder, open IHI London, and you can just open the PDF. That one there. Okay. And what we've been doing is actually taking patients that were patients on some of these frontline units and bringing them back into the hospital to be a part of the team, teaching them also the process improvement skills and having them work directly with the actual staff to make the changes on the unit. So it's very much, as we described, a redesigning of care processes, but by directly involving the patient in the actual redesign so that the staff starts to understand what is really the perspective of the patient, how are they seeing the care that they're getting, and when we redesign something, does it really meet their needs? So I'm going to give you a little bit of context, talk about the program, and then try to focus primarily not on the tools we're teaching them. I'm sure you've seen them all before, 5S, process mapping, but focus more on some of the stories we have from patients and their involvement. So just quickly, context, as I mentioned, we're from Montreal. I'm from Montreal, Canada. We're a very large system. We're 5 hospitals, academic teaching centers, plus 1 community. We have about 1,100 beds, 14,000 staff. We are a bilingual organization, which is probably not unusual for Europe, but a little unusual for Canada. And we are extremely multicultural. So these are all a little bit unusual characteristics for us. As I mentioned, we're 6 hospitals. You can see some of the dates there, which again, by European standards are probably not that old, but for Canadian standards they are, and a lot of these organizations right now, a lot of their facilities are under a state of severe disrepair. So we are moving into a major new facility. 3 of the actual physical hospitals will be closing. We'll be moving all the staff and all the patients and all the operations to a new facility, which is just under construction right now, and we'll be moving in very shortly. And so part of the impetus for this program is to really get staff to be able to prepare for the move and change their processes. When they get to the new facility, they're able to work in a new environment. And so we're trying to break them out of the traditional ways of doing things. On top of that, we have some additional context, which is probably not unusual to yourselves, and you've seen this in your environments: budget pressures, demand for improved quality, shortage of frontline staff, and then we have these complex work environments and very outdated processes. So the program itself, Transforming Care at the Bedside, as I mentioned, is a program from IHI. It's meant to, as I said, to put the improvements in the hands of the frontline staff, and it has kind of 5 pillars or 5 focus areas. We took the objectives of the project and really kind of made 3 of our own. The first one, to increase nursing time and direct care at the bedside by teaching them these skills so they can actually make the changes on their own when they need to, without waiting for an outside consultant or a manager to come in. They can really start applying these skills on a daily basis, on a repetitive, rapid basis to make changes. But then our other 2 objectives were really to involve the patients directly in the changes and also to have the staff understand what patients are feeling and seeing from the processes that they have right now in the care that's being provided. So just a quick timeline. We're in wave 1. This is the timeline for wave 1, which is 2010 through 2011. We have 2 subsequent waves. We're about to start the next wave. They're all broken down about 3 modules. And we've created our own modules where the second module is called Patient Experience of Care. And the idea is that in the first module, when the staff and the patient reps have learned some of the skills of quality and process improvement, the second module and the second time is really an opportunity for the patients to describe to the staff what they want to see changed on the unit, how they want the care process to be changed, what kind of improvements would they like to see. And they use the skills taught in the first module, apply that to the second, and they start working more on the patient's perspective, from the patient's perspective. And then the third module, again, it's kind of a combined, bit more of a combined effort. So these are some of the pilot units. It's just to give you an idea as to the breadth of the units we work with. So there's medical, surgical, psychiatric. We're now going to pediatrics, as well as we've had mental health. The teams consist of, you know, the usual frontline caregivers that you've seen, including physicians, but there's always at least 1 to 2 patient reps. We try to have 2 because these are our patients. They are our patients. And as was mentioned earlier, my patient rep for the unit that works not for my specific unit, but for one of the units, who is supposed to be here today to give her experience of this, she's ill and unfortunately couldn't attend. And that's kind of something that we have to deal with on a regular basis with some of our patient reps, because these are still patients on the units. But the insight that they give us is incredible. So some of the tools and measurements, as I said, some of the tools we use, they're things you've heard before. PDSA cycles, we teach 5S as a lean technique, process mapping, and some other interventions. These are some of the measurements. So we try to measure not only the performance, so are we actually, you know, our turnover rates going down, are staff more satisfied by the new environments, are they spending more time in direct care, but we also start measuring the patient's reaction. So what are they seeing from the new processes? I'm going to go down to the modules and talk about them, because I want to give you examples of what the staff has done in some of the modules, and then how the patients have influenced those changes in those modules and what they've done. So module 1 starts off with teaching PDSA, which I'm sure you're all very familiar with. Here's an example of one of the PDSAs that was done by the staff. They wanted to improve the time to report, so they used an S-bar technique, which is a simple way of communicating very effectively. So it's you provide situation, background, assessment, and recommendation. And they saw that their average report time went from 34 minutes, almost cut it in half. So it's a much faster kind of turnaround when they're providing report. What the patient said is, I have to provide my information multiple times to multiple people, and it's always the same information. So the patient rep in this one particular environment, and this was mental health, and the team there, they decided that they were going to try to do team reports with the patient. So everybody comes in together into the room with the patient, which for our environment is not typical. It's actually a rather unique way of doing it. We know it might be best practice, but it's not something that we necessarily have in place. And so this is an example where the team, all the clinicians, whether they be the nurses, this is a mental health unit, so there's psychiatrists, also the other physician team, they all come and interview the patient at once altogether and get the information, so the patient doesn't have to repeat it. The other part of this module also is 5S, which is teaching that lean technique to improve your work environment. These are just some kind of before and after pictures of some of the supply storage areas we have. As I said, these are old facilities, so they don't exactly have the best environments. And they tend to be very cluttered, full of equipment, not very accessible. And so the staff wanted to change that and make it easier and safer for them to access equipment. So these are examples. This is kind of done all through the hospital. And here's another example of doing the same thing, but with their document center around the nursing station. So as you can see from the spaghetti diagram, it took them over 2 minutes just to access some basic documents for an admission. And after they did applied 5S techniques, they reduced, obviously they're walking to basically a straight line, and it takes them about 30 seconds to get the documents they need. So very basic concepts. A lot of the units wanted to do similar things, but one of the patient reps on one of those units said, the most important thing for me is the family room that needs to be redesigned. And we need to apply 5S to the family room. And the staff said, family room is great. It's clean, it's organized, there's no problem. And the patient rep, and it's actually Cheryl, who couldn't be with us here today, her comment was, your space that you call a family room has a lot of information that for patients is not relaxing, it's not supportive, it's not encouraging. So you have cancer pamphlets on the wall, educational information on the wall, you have sharp containers on the wall. The room doubles as an interview room for families. It's actually a pre-op room for interviews. It's not a family-centered room. It's not a patient-centered room. So what they did was they removed everything in that room that had anything to do with your disease. And they put up pictures, and they cleaned it up, and they repainted it. There's nothing in this room now when you go into it that has anything to do with it, that says anything that you're in a hospital. There's no sharps containers, there's nothing in there. So the patients come into the environment, and this is their environment. So this is actually their their space where they can come and relax with their family, and in cases where they need to, they can grieve together and they actually have that space. So that was something that the staff never saw. They thought their room was perfect. But when they asked the patients and they asked the families for which the room is intended, they said, it is the worst space we'd ever want to be in. So it was a very interesting learning for the staff. The next module was patient experience of care, and we suggested that they try some bundled interventions, so apply whiteboards and comfort rounds and therapeutic questions that patients have said these are things we'd like to see. The first one was we started with whiteboards, so again, a lot of organizations have this, we don't have them everywhere. We put them up, and right off the bat, staff found it very effective. Patients did as well, but it was basically for communicating basic information about where I am and what the patient room, what my room number is and my extension so my family can call me. And the physicians started using it and staff started using it to describe the procedures that were coming or their plan for the day. But the interesting twist that happened is very quickly, patients started using the whiteboards to encourage and support their family members. So you can see there's this incredible picture here that was drawn by one family member as a supportive image, and I'm not sure if it's an image that the patient is familiar with, but it was really meant to say, this is where you live and this is when you're going to be able to get there. So it's an interesting way of describing your discharge time rather than just simply writing Tuesday at what time. They also started writing even other supportive messages to each other or to caregivers. So please put splints not too tight, thank you. So they started really communing back and forth in a very unusual, unique ways, and I don't think that the staff had really initially thought that it would be used for this purpose, but it's become a very effective tool. The final module is around admission and discharge processes, so we really wanted to focus around that. We wanted to teach the staff how to do process mapping so they could look at their processes more in depth and try to tackle some of these complex processes and make improvements. So we taught them how to do process mapping. This is an example of a process map. It's an admission and discharge process for a single unit. You can see it's quite extensive. It takes a long time to do. Here is a swim lane, a swim lane of the current process, and then how they designed it afterwards. So again, the staff became very engaged in this. They started to learn how to apply these tools, and in the room at all this time was the patient. So they're watching this and learning this as well. And what they're starting to recognize is not only some of the difficulties there are in the process for the clinicians, but they started recognizing that there's things missing in there for patients. So out of that process, one of the patient representatives with their group decided we need a patient discharge checklist that goes to patients. So not just the clinicians have their checklist as to everything that was done, do I have my discharge orders, et cetera, all that, but really for patients, have you asked these questions, do you know this information, do you know where you're going, et cetera, and they put this together. So again, it's just an interesting take on that. They saw what was happening in the process, they learned the ways that they can improve things, and they created something for themselves with the support of staff. So just into some of the results, and I know I'm going a little bit quick, but I know we're also short on time. So this shows you some of the direct time and care results we've had. So as I mentioned, we started in 2010, it's now 2012, it continues. We're gone now on 8 different units across the hospital. We have another 8 units to go. We've had an increase in the amount of time spent in direct care, and we've also had a decrease in the amount of waste, that there is in our processes. We also have some results on improved responsiveness to patients, improved communication around medication, and some improved rates about staff turnover and overtime rates. I have to say that the improvements are all fairly small, and we're only at about 8 units, as I said, out of about 60 units that we have across the hospital. But the learning that's gone on is quite significant. And I'm reminded of a conversation or a comment that was made yesterday in a session that was with Dr. Kaplan around Virginia Mason. And he has a colleague with him, Mr. Silverstein, I think his name is, and he mentioned, it's a common phrase, the journey is more important than the outcome. And I think what's happened here, just to get to these points, just to have staff take the time off the unit to learn these skills, and then take the time with the patients, really to hear the patients, to make these achievements is quite significant. And now this is starting to spread fairly quickly through the organization without having to have these formal interventions and this formal training. They're starting to learn the skills and apply the skills outside of their units, and they're starting to really ask patients. And not just ask them in a survey, but ask them if they're comfortable, if they're ready, come out of your patient room, come with us, come and sit in our staff room where we have these process maps up on the board, we have brainstormed all these ideas, and tell us what you think about all this, truly. Obviously, some patients are more comfortable with that than others, but those who are, it's a wealth of information. So some of the lessons learned, patients said that the 5S module was a turning point from them because they could actually get engaged and finally tell the staff what they think of the environment that they're in. There was always a thought at the beginning that patient's perspective would vary too significantly from the clinicians, but they actually can be reconciled, and they found that they could. They found that we used patient reps to go and speak to other patients on the unit, and they were able to get more information directly, because patient-to-patient communication is sometimes easier than with staff. And many of the patients want to be engaged, and they didn't really know how, and this gave them that opportunity to really be a part of something. The staff, obviously, they found, and I've highlighted some of the big action verbs here, so they could actually create a healthier environment. It empowered them to make the changes themselves. It taught them to make the changes, so they didn't have to wait for managers, so they were actually able to accelerate that. It fostered the buy-in from the entire care team, and then it enabled those team members to become resource people for others as well outside of the group. As I said, currently we have about 8 units running, and we're about to wrap up the second wave, and we're about to start the third wave. And the most important thing we're challenged with right now, and I would say it's a challenge, is actually sustaining these improvements and continuing the skill development. It is very challenging to do in our environment. It's not something that comes naturally to clinicians. I'll speak for our environment, because they tend to be very reactive to situations. It's difficult to take them out and give them the chance to think and learn a new skill, but it seems to be progressing very well, and we're very hopeful for the future. So here's some of the acknowledgements. Again, there's been huge support, not just from various foundations, federal agencies, but also of our staff, our leadership at the hospital, and more importantly, our patient representatives. They have their own council, and they're very supportive of the program, and they push it, and their representatives on the board constantly bring to the board, what are you going to do more about this program? How are you going to expand this program? So we're very thankful to them. Thank you very much.
Thank you very much, Justin. Thank you. We're time for a couple of questions. Hannah, anything coming on tweet? Any questions? The lady here, yes? Could you introduce yourself, please?
Dr. Excellent Marilena. I'm running HIV/AIDS program in Haiti, which is St. Damien Hospital. It's a pediatric hospital. And actually, I'm leading also the Quality Improvement Committee. And we involve one patient in our committee, and he gives feedback. My question is, as you have a patient representative, did you have criteria to select them, because you will have to train them along with your staff? Thank you.
So we didn't necessarily have criteria to select patients, no. We actually, the only criteria I would maybe say that we had is that, one, they had to be interested in going on this journey and be able to spend the time with us and know the environment. But there was no specific criteria. We didn't have a lot of patients that were available or could volunteer for this, because they all have their health problems, or some of them didn't actually want to be in the environment after that. But there was no set criteria for it. The ones who wanted to be involved, they were more than welcome to be involved. The more we could get in the doors, the better. And we found ourselves having to find interesting ways to accommodate their participation, because we had patients coming in wheelchairs, and some of our conference rooms didn't have doors big enough for wheelchairs. So, we really learned from the experience of them participating, but we opened the door to whoever wanted to participate in the teams. Yeah.
One final question.
Nadim Mogul, pediatrician from Newcastle. Fantastic work, very inspiring, I have to say. The work that you're doing at the patient level, the floor level, I'm interested to know, when is this going to get to patients sitting in all those very important committees, and then patients sitting in the recruitment of staff, and then patients sitting and informing the board?
I would say, so when will it happen? It's happening in some ways already. So the patient committees that we have right now are becoming more aware of this, and a number of those members sit on the board. And so we've been able to present at the board a number of times, and those patients constantly talk about this at the board level. But you're right, the next piece is, how do we get them even more involved, whether it becomes recruiting of staff, looking at our performance, not just our quality performance, but patient engagement performance, and really helping us design our future. It's not quite there yet. This is a starting point. It's been, as I said, the actual outcomes have been small but important ones, but the experience of involving them in the process has been incredible, and now it's starting. We are hoping to be a part of our culture. We don't make a change, we don't make a decision without involving the patients in that discussion directly.
One final question.
Thank you very much. My name is Julie Wells. I'm from the UK. Thank you for your presentation, and I think you described it in a way that showed how empowering this work is, both for patients and for staff. And I wondered whether you've talked about that it's small scale at the moment. I wonder if you've been thinking about what your spread strategy is, because I think we often are challenged by moving from a few wards that do very well to large-scale change?
So we have been thinking a lot about that, and we actually have a couple ways we do it. So we've identified how many units across the organization we think we need to formally train in these skill development, but also in this way of thinking with patients in order to just get natural spread. So we've targeted almost half of the total number of units. So we think if we formally take half the units through the program and have patient reps supporting them, the other units will start participating, which they are, so that seems to be working. The other thing we're doing is instead of just teaching everybody the whole program, we're doing mini sessions with all the staff as much as we can, and primarily this is a nursing-led initiative, although we involve all the other staff that we can, physicians, allied health, etc. And we do mini sessions around specific skill development, and we try to involve the patients in that as well. So we're starting to create little workshops. But again, as I said at the end, the biggest issue will be really engaging that, making this a part of the culture and sustaining it long term, which we are trying to do and working on, and it's fortunate that it's becoming more and more recognized. People use the language around our hospital that they're going to TCAB this, or they're going to talk to someone about TCABing something, and now they're going to talk to their patient rep, and they call us and ask how we can support them, etc. So it's started, but it is a challenge.
Justin, thank you. Ladies and gentlemen, 3, I think you'll agree, inspirational speakers. Thank all of you, Kazui, Nino, and Justin. Thank you very much, ladies and gentlemen. A round of applause.